We're going to work back here to chapter 20. This is cardiac emergencies. Just like other sections that we're going to go over, anatomy and physiology briefly is covered here first. But we're going to talk about ACS, or acute coronary syndrome, and what that means. We're going to then move on to cardiovascular disorders that you will be able to hopefully identify in the field and begin to learn to manage. Okay, so let's touch on some A&P of cardiac here. The cardiac system, or the circulatory system, is composed of the heart, the vessels, and blood. So the blood is the fluid. It is made up of red and white blood cells. It also includes the platelets used for clotting and plasma, which is the liquid portion. The flow of blood through the chambers of the heart is unique, and it must travel in a certain sequence in order for circulation to occur efficiently. Once the blood leaves the heart, it is going to travel through arteries, and then arterioles, then capillaries, and on its way back to the heart, it travels through the venules and the veins. Keep in mind the circulation of blood between the heart and the lungs, and the heart and the rest of the body are coming from different areas, mainly the right versus the left side of the heart. So we mentioned blood as being the fluid. The vessels are usually the tank, and the heart is the pump. The heart's job is going to be getting the blood to circulate through the rest of the body. This has to be done with force. So the generation and distribution of electrical charge travels through the muscle of the heart. This causes a mechanical response or compression of the heart, allowing it to contract and thus force the blood from that particular chamber wherever that chamber leads, whether that's from the atria to the ventricles or from the ventricles out to the lungs or to the rest of the body. This blood has oxygen, it has nutrients in it whenever we are pumping it out to the body. Now, when we are pumping it to the blood, we are pumping it, to the lungs. When we pump it to the lungs, the idea is that we're going to offload carbon dioxide and onload the oxygen. Here we're looking at coronary arteries, and this is the cardiac circulation. So these are the vessels that actually supply oxygen to the muscle of the heart itself, because inside the heart, where we're pumping blood, is not where the heart is getting its oxygen. It's being fed from these particular arteries. These arteries include the right coronary artery, the left anterior descending artery, and the circumflex. And the circumflex kind of wraps around to the back side of the heart. You can see where these come right off of the aorta. So as the blood is being pumped from the left atria to the left ventricle, it is then flowing into the aorta, and thus that blood flow is able to travel to feed the heart. So how does the normal function of the heart and blood vessels relate to blood pressure and distal pulses? Well, we know that the blood has to travel through the vessels, and if we do not have enough pressure, then you're going to have a low blood pressure. If we have a low blood pressure, it causes circulation to kind of be slow, and we do not get the force that we want in order to get good perfusion at our distal sites. So our distal pulse is going to be low with a lower blood pressure. And if we have a systolic blood pressure of less than 90, you probably won't even have a radial pulse. Well, how is shock then related to the function of the heart and the blood vessels? Well, the idea is the heart and the brain are the most essential organs of the body, and the body knows this. So in shock, it's going to vasoconstrict all the vessels towards the periphery so that the blood primarily stays in the core and is able to feed the brain and the heart. Acute coronary syndrome, sometimes known as ACS, may also be called cardiac compromise. This is when we're dealing with blood flow that feeds the heart being blocked or disrupted for some reason. So there's a number of things that might cause this and fall under the ACS category. Now understand that the body is smart and understands that the brain and heart need oxygen in order for us to survive. So these are the last organs that are going to go without oxygen. However, they're also very sensitive organs. So the heart muscle, if it does not have oxygen, it will begin to die. And death of that heart muscle can lead to lifelong complications, including death, if not corrected quickly. Most often, these hypoxic conditions are going to be called ischemia. And ischemia is kind of like a bruise, right? It's where we've got a little bit of damage and it's probably going to come back. However, we have to be sure that we are doing everything in our power to correct the condition. These cells will again die quickly if we do not restore blood flow. When acute coronary syndrome occurs and we have a lack of blood flow to the heart due to a blockage or disruption somehow, the individual many times will complain of chest pain. Sometimes it's a pressure or a squeezing or an aching, and it's located in that mid-sternal area of the chest. Not everybody has these symptoms. A few other symptoms that they may complain of include radiation of that pain to the jaw or the neck, especially of the left side, radiation of pain to the arm, especially the left side, or the upper abdomen. Shortness of breath or dyspnea is also a common finding in older patients and women. Know that not everybody is exactly the same, so we've got to use our assessment skills along with the information the patient is providing to us to identify what is going on and correctly identify acute coronary syndrome. The chest pain is probably the most common or most heard of symptom that we have with acute coronary syndrome, but some other symptoms that may occur include nausea or vomiting, syncope, which is lightheadedness or passing out, sudden onset of sweating, and this is usually profuse sweating, drenching their shirt, abnormal pulses, either fast or slow heart rhythm, abnormal blood pressure. Many times it's going to be dropping lower than normal during these episodes because the heart is not able to pump. And anxiety or feelings of impending doom can cause it to be difficult to take care of these patients. It's very important that we provide some emotional support as well as our other medical interventions. Upon dispatch, you may get some information regarding the patient's chief complaint, but upon your arrival, you need to do your patient assessment. This is true for any and all patients, but again, with acute coronary syndrome, we need to do that primary assessment, make sure that the ABCs are working. We need to think about the chief complaint that the patient is stating, use our OPQRST and our sample in order to get a good history of what's going on, and we need to get a good set of baseline vitals. These baseline vitals are going to be important as we continue our care with the patient to identify the trend on if it is getting better or getting worse. So again, think about what the patient is complaining of. Think about the associated signs and symptoms as well. So we've got pain, pressure, or discomfort in the chest, the jaw, the neck, the arms, or the upper abdomen. Again, many times this will be on the left side, but it may be on the right. The patient may complain of shortness of breath or some difficulty breathing. They may feel like they're having palpitations, like their heart is doing flip-flops. And a sudden onset of the sweating, nausea and vomiting types of symptoms is a red flag that, again, we had something happen that is beginning this process with our signs and symptoms. Syncope, lightheadedness, passing out is a concern. It tells us that the brain is not getting adequate blood flow. Anxiety is absolutely something that the patient may begin to feel, and this anxiety may make them very unsettled or not want to sit still. They may have some generalized weakness with this as well, though, too, because the cardiac muscle is not able to pump efficiently, which means the muscles are not getting supplied with that oxygen-rich blood either. Abnormal pulse and abnormal blood pressure are also things we're likely to see. When you see these patients or you're walking up to these patients and you're starting to kind of do that physical exam, even before you touch the patient many times, you will see them grabbing or clutching the center of their chest. It's a pretty universal sign. You may also see them sweating, and again, it's usually pretty profusely. You're not likely to miss it. Their skin color may be pale or even gray, and you are likely to notice their restlessness or that anxiousness that they are feeling. Remember, if the pump of the heart is not functioning well, then we might also get a backup of fluids. So we may see swollen ankles or feet. We call this edema. We may also hear crackles in the lungs, which is a sign of acute pulmonary edema. Again, the fluid is backing up into the lungs because the heart is failing. Check your patient for any medical alert jewelry. Some patients do wear a bracelet or a necklace that might state that they have a medical history, such as diabetes or stents or something along those lines. So as you are examining your patient, look for those key pieces of information. So 12-lead ECGs are interpreted by paramedics or advanced level providers. This is not a skill of the EMT. However, the EMT can help by placing the electrodes on the patient. So this is helpful so that the paramedic or that higher level can focus on maybe starting an IV or doing some other advanced skills. The EMT is going to place the leads and they will then get the tracing. That tracing again can be interpreted by their paramedic partner or a provider at a higher level. We also now have the capability of transmitting that ECG to the hospital. So let's prepare our patient for that ECG or electrocardiogram. ECG is the same as EKG as well, so keep those two together. But first of all, we're going to place the patient in a position of rest. Most of the time, we prefer that the patient lay fairly flat and not move during the reading. And so we're going to place our electrodes on the chest. Be sure that the electrodes each have a secure connection with the skin. If there's jewelry or clothing or things in the way, we've got to take them off. Yes, that means we need to expose the chest. Remove any sweat, dead skin cells, excess hair, medication patches, anything along those lines that might be in the way of where our patches need to go. Our pad placement is extremely important because these patches send electrical impulses in every direction, and by looking at that EKG, the higher level medic can identify what is going on with the patient, and that may include a heart attack. Now, once they identify this acute coronary syndrome, they can actually pinpoint where in the heart this is happening because of the placement of those ECGs electrodes and where the issue lies on the 12 lead. There are some images in your book you'll be able to follow along. 12 lead ECG placement starts on page 561. The 12 lead is interesting because it's really only 10 leads, even though we call it a 12 lead, because of all of the angles of the heart that it's going to look at. So first of all, we want to place our limb leads, and these are going to go on the inner aspect of the wrists and on the inner aspects or tops of the ankle. They are labeled right and left, so look at the actual electrode as you're putting it on. Now I will tell you when you're placing these electrodes too, put the sticker on the electrode and then adhere it to the patient. Do not put all the stickers on the patient and then try to snap those electrodes on, because you do have to push pretty hard sometimes and it can hurt the patient. Now in step 2, we are placing the V1 and V2 leads. The V1 and V2 leads are placed on the chest, and they are going to be placed at the 4th intercostal space, between the 4th and 5th rib on either side of the sternum. So V1 goes on the patient's right side, V2 goes on the patient's left side. Place V4 and V3 leads. V4 is going to go down the left midclavicular line, and we are going to place that lead in the 5th intercostal space. Lead 3 is going to be located between V2 and V4 as it kind of rounds around with the rib. Then V5 and V6 are the last 2 leads. V5 and V6 are placed also in the 5th intercostal space, but the V6 lead is going to go mid-axillary line, so that's right down their side along that intercostal space, and V5 is going to go just between V4 and V6. Here you can see an image of those limb leads. Again, they are labeled right and left, and then arm and leg. In these images, I want you to begin counting from left to right. So lead 1 is the red lead that you see on the right side of the patient's sternum. Lead 2 is the yellow lead. Lead 4 actually gets placed next. And remember, this is not nipple line, this is mid-clavicular line. So you must expose the chest to be in order to see the patient's clavicle, and then follow that down to that 5th intercostal space. Lead 3 is going to go between lead 2 and V4 there, you can see it. Lead 5 is orange and lead 6 is purple. I like to put lead 6 on first because I know it's going mid-axillary, again still following that 5th intercostal space, and then lead 5, as you can see in the image on the right, goes right between those lead 4 and lead 6 placement and in that 5th intercostal space as well. So if we arrive on scene with a patient who is potentially having an acute coronary syndrome, there are a few things we really need to do and focus on. First of all, we want to put the patient at physical and mental rest. Find a position of comfort and let them try to relax as much as possible. Identify if we need to give some oxygen. If the patient is in respiratory failure, they're having agonal breaths, or they're apneic and not breathing at all, then we need to get moving a little bit faster. Remember, part of our primary assessment is the ABCs, and obviously this patient is having an issue with those. If we do identify that the patient needs some respiratory assistance, we may have to use our bag valve mask and provide artificial ventilations. But if we just need some oxygen, we might be able to just give some O2 via the non-rebreather mask or the nasal cannula to help the patient get their pulse oximetry readings up. If we don't see any signs of distress and our pulse oximetry reading is at least 94, remember we really like to see 95 and up, but if it's at least 94, we do not have to apply oxygen to this patient, but you need to continue to closely monitor them so that if there are any changes, you can address them quickly. If it's appropriate with your service and you have adequate training, you can get a 12 lead at this point. We like to get that baseline 12 lead just like we like to get a baseline set of vitals so that we can compare it to later EKGs to see if there are any other changes that come throughout the time that we are caring for the patient. Make sure that you follow your local protocols. Some require that these EKGs be transmitted to the hospital prior to your arrival. Some recommend that they be transmitted. but at least someone should be taking a look at it, whether that's someone in your service that's with you or someone at the hospital. For these patients, we do want to administer aspirin. Aspirin is going to be administered at 325 milligrams. This should be a non-coated aspirin. These do not taste very good, and the patient is instructed to chew it up. Now, we can also use baby aspirin. Baby aspirin are 81 milligrams, in which case we can provide 4 baby aspirin for a total of 324 milligrams. Again, the patient is going to be instructed to chew it up and then swallow. Some patients, however, cannot take aspirin. So if your patient is at risk for aspiration, maybe they are altered, they're unconscious, they are not going to be able to control their airway as we instruct them to chew and swallow, we would not want to give them this medication. If they've already taken a full dose of aspirin at home prior to your arrival, we do not want to give them another one. Many individuals with cardiac histories are instructed to do this, so find out this information before you administer your aspirin. Identify allergies. If the patient has an aspirin allergy, we would hold the aspirin. If they have a recent GI bleed or bleeding ulcer, we would not want to give them aspirin for fear of making their condition worse. And if they are on a blood thinner, giving them aspirin is not going to serve a purpose. The patient is already on better medication to help to prevent the blood from clotting. The bottle of aspirin you see here on your screen is chewable aspirin. If you look real close at the picture, you can see that it is 81 milligrams. And if we are giving 81 milligrams and we know we want to give a total of 324 milligrams, we're going to need to give them 4. It's also likely to be in your protocol for ACS patients, administration of nitroglycerin. Nitroglycerin is used for chest pain. The idea behind nitroglycerin will be covered more in pharmacology, but it's going to cause vasodilatation to hopefully open up the vessels so that the heart can get the blood flow it needs. Patients are likely to have this if they have a history of cardiac problems. The physician that they see may have prescribed this to them, and if they have that nitroglycerin, then we can assist them in that administration. Nitroglycerin comes in a couple of different ways. Here on the screen you can see the bottle of nitroglycerin. This has small little tablets in it, and those tablets are placed under the tongue. They will dissolve on their own, but they are placed there because of the mucous membranes and their rapid absorption into the bloodstream. The other form of nitro comes in a spray. You'll find that on page 568 of your textbook, and you'll identify this by the label on it. Understand that you're going to provide a spray underneath the patient's tongue with this nitroglycerin. Again, it's the same place that the tablet would be used, but it's just delivered a different way. When we are going to administer nitroglycerin to a patient, there are a few things that we have to be sure of before we administer it. Obviously, if they were to have an allergy, we should not administer it to the patient. Their systolic blood pressure must meet your protocol criteria. Typically, that is to say that they have a systolic blood pressure of 90 or more. Remember, systolic is the top number of your blood pressure. We do want to ask patients if they have taken Viagra or any other erectile dysfunction medications for the last 48 to 72 hours. Please understand that this is not just a question to ask men, but we also need to ask females because some females are also prescribed these medications. And then medical direction needs to authorize us to administer the medication, and that will give us the green light to go ahead and assist. Sometimes one nitro is not enough to really improve the patient's condition, so we can repeat the dose in 5 minutes if the patient is not having any relief, their systolic blood pressure is still higher than 90, or if we get direction from medical control to give another dose. Again, repeat the nitroglycerin in 5 minutes. If after 2 nitro, the patient is still not having improvement, they are still having this chest pain, their vital signs are not improving, maybe we need to think about moving to the hospital with this patient, but we also want to make sure that their blood pressure remains above 90 systolic. So nitroglycerin again can be administered a total of 3 times, with the doses being 5 minutes apart, pending the patient still meets criteria. There are many cardiac disorders out there. We're going to cover a few that you are most likely to see in the field. Coronary artery disease is a condition where fatty deposits build up on the lining of the arteries. Now this is on the inside of the arteries, and because of this, it's going to narrow and can even block the arteries, and especially the ones of the heart we become more concerned about. If we have a higher percentage of blockage or even 100% blockage of those coronary arteries, we know that that's going to lead to some problems in the future. Some people may say they have heart disease, or they may identify as having coronary artery disease, but people do have risk factors that weigh into their potential diagnosis. So coronary artery disease is hereditary. It can be seen in grandparents and parents of patients who are diagnosed. Age can be a factor. The older you are, the more likely you are to develop coronary artery disease. High blood pressure. If you have high blood pressure that is uncontrolled, it's going to speed up the process of coronary artery disease. Obesity. Lack of exercise. Those individuals who live very sedentary lifestyles where they just sit around and watch TV all day. Elevated blood cholesterol and triglycerides. Triglycerides are a portion or a type of cholesterol that we tend to monitor. And if we have elevated cholesterol and triglycerides that are not managed, then we can have coronary artery disease develop. And also those individuals who smoke cigarettes. Many of you have probably heard of the term angina. Angina pectoris is a condition where, because of the narrowing of those arteries, any time that the heart needs more oxygen because of physical exertion or stress usually, we can't get enough blood flow through there, and so the heart is kind of crying out for more oxygen. The patient will then experience chest pain. Angina is something that is many times a precursor to a myocardial infarction. Lucky for us, angina usually responds to nitroglycerin. Nitroglycerin is likely prescribed to patients who have a history of angina, and with nitro we know that it's going to dilate the blood vessels. This includes the vessels feeding the heart. That's going to allow more blood flow to get to the heart muscle itself and hopefully alleviate the patient's discomfort. Now, I will tell you, we cannot in the field identify the difference between angina or a myocardial infarction. So it's important that we treat both of these patients quickly and aggressively. We want to put the patient at rest, and I had said that previously, physical and mental rest. If we put them at rest and their pain improves, we know that it's likely just angina. However, we always want to assume the patient is having an MI, and that means we need to transport them to the hospital. Nitroglycerin, again, will usually help improve the patient's discomfort, but we cannot assume that the patient is not having an MI along with it. Think about giving the patient some oxygen, the aspirin and nitroglycerin that we talked about. We also would like to get a baseline 12-lead EKG with our baseline vitals so that the ER provider will be able to determine if any other changes have occurred. Be sure that you transport these patients quickly to the most appropriate facility. Myocardial infarction, or MI, or heart attack can be caused by a couple of things. First of all, we may see hardening plaque in those vessels, causing that vessel to rupture because of pressure. This is called an aneurysm, but the heart muscle itself, past the point of this aneurysm, is not going to be getting any blood, and therefore is going to be starving for oxygen. We talked about narrowing of the vessels, and if those vessels become completely blocked, this occlusion causes an issue where, again, anything past the point of that blockage is not getting blood flow and is not receiving oxygen. Another reason an individual may have an acute MI is if they have a thrombus or an emboli. Now, a thrombus is an occlusion of blood flow due to a formation of a clot. And this is a blood clot that is then blocking or obstructing the vessel, so the heart is no longer getting its supply of oxygen. Sometimes a thrombus can break loose and form an embolism. An embolism can move on and totally occlude that smaller artery. Blocking of an artery by thrombus or embolism is an acute MI. These are the patients who are going into the cath lab and are going to be managed surgically. So if you take a look at this image on the left, you can see the left anterior descending artery coming down kind of on the front side of the heart. Now, typically, this is going to branch off and branch off. It gets smaller and smaller, and these are the vessels, again, that feed the heart oxygen. But you can identify this area where the infarct has occurred, and those vessels have been cut short up at the top of that purple margin. This cross-section on the picture on the right shows that the infarct is not just on the outside, but that blood flow, that lack of oxygen, has affected the entire depth of the heart muscle. So when we have these acute myocardial infarctions, remember I said there are a few things that can happen. Sometimes we have ischemia, and this is injury to the cells and some cell death. This may cause some disturbances in the electrical function, but usually ischemia will not kill the patient. This is just going to cause the heart to become weaker. Dysrhythmias can occur. These dysrhythmias may be changes in the rate, rhythm, and pumping ability of the heart. We've talked in the resuscitation chapter about ventricular fibrillation and ventricular tachycardia, and those are the dysrhythmias that are going to be most life-threatening. When we have a myocardial infarction, again, remember, we are not getting blood flow to the heart, and shock is also known as hypoperfusion. It has a special name, though, when we talk about acute MIs, and we call that cardiogenic shock. Acute MIs can also lead to sudden death. We actually diagnose sudden death as anyone who has cardiac arrest within 2 hours of the onset of symptoms. So when we say sudden death, we don't mean that they were just walking and dropped over dead. If they actually die within 2 hours of initially complaining of the chest pain or whatever symptoms they're having, then we would consider that a sudden death. So treatment of these AMIs, or acute myocardial infarctions, are going to include one or both of these treatments. One of the treatments is known as fibrolytics, and fibrolytics are medications that will help to dissolve a clot that's already there. Balloon angioplasty is another type of treatment that can be completed for these patients, and this is a surgical procedure done in the cath lab where they will go in and actually thread a balloon into the vessel. They blow the balloon up, which causes any plaque or whatever is in the vessel to compress against the walls of the vessel. Sometimes they will actually put a stent in place to help hold that vessel open. When we see these patients, we take care of them, and as they recover from their MI, they're likely to be discharged home. When they are discharged home, it is very common for these individuals to be placed on aspirin therapy and a beta blocker. Now, aspirin therapy is going to be taking an aspirin every day with their normal medications, and taking a beta blocker helps with the contractility and the efficiency of the heart muscle. Now remember, assessment and treatment for these patients, we always start off the same. We're going to do that primary and secondary assessment. Issues with primary means that we take care of them before we move on. But as we are looking for patients to potentially identify myocardial infarction, know that we may also see the similar symptoms that we stated in ACS. That's going to include chest discomfort or chest pain, shortness of breath, nausea, vomiting, syncope, and sweating. For these patients as well, we know that we cannot treat them in the field. We can try to manage them and keep them alive until we get them to the hospital, but time is of the essence. We need to restore blood flow to that area of the heart, and the hospital is the location to do that. We can, however, get our 12 lead, and we can contact ALS for a possible TEER or assistance. Be prepared for cardiac arrest. Individuals in a myocardial infarction are not getting the correct blood flow to the heart. And if that continues and it's a large enough area, this patient is going to stop having a pulse. Provide your aspirin and nitroglycerin, as we had mentioned before, and keep close eyes on your patient. Now, heart failure and acute pulmonary edema, they kind of go hand in hand here. Well, heart failure is also known as congestive heart failure. Now, this can occur on one or both sides of the heart. You can have left-sided heart failure, right-sided heart failure, or both. This is when the heart is unable to pump blood efficiently, whether it's just that the muscle is weak and it just doesn't have the force or the contractility to be able to do it, or if it's been damaged for some reason. But because the heart cannot pump efficiently, we can't perfuse the body efficiently. Things that require increased oxygen demand are going to be more difficult for these patients. So exercise-related tasks, walking up a flight of steps sometimes, cause these individuals to become pretty short of breath. Limited ability to compensate for challenges, and that's because if we are already in heart failure and we know that the heart is not able to pump as well as it should, we might see other body systems also being affected. And when we have heart failure, fluid can build up. When we have right-sided heart failure, the blood is backing up, and we are going to notice certain symptoms. So in right-sided heart failure, what are we going to see? We're going to see pressure building up in the right atrium and the superior and inferior vena cava. Remember, it's backing up. So what leads to the right side? We've got jugular vein distension. We've got swelling and fluid buildup in the abdomen. Many of these patients are going to have swollen ankles and feet. Left-sided heart failure also is a backfill of fluid leading into the left atria. Well, we know that that fluid is coming from the pulmonary vein, from the lungs. The problem here when we have an increase of pressure is the fluid begins to leak into the alveoli, and gas exchange is now impaired. The patient is likely to be short of breath, and upon auscultation, we may hear pulmonary edema, also crackles. This can be life-threatening, and the patient will feel short of breath and may feel like they are essentially suffocating. Talk to these patients or talk to their family members and get a good history. Do they have a history of heart failure? What medications are they on? Are they on medications such as Lasix or other diuretics to help rid the body of excess fluid so that they don't develop pedal edema or pulmonary edema? If we see swelling in the abdomen or buttocks, if we identify JVD, those should all be red flags that something is going on with the patient. They are not normal findings. Again, when we do our assessment and we auscultate the lungs, it's likely that we will hear the pulmonary edema with crackles. The patient is going to be complaining of some difficulty breathing, and they may be coughing up some sputum. Pink frothy sputum is a telltale sign of pulmonary edema and left-sided heart failure. These patients have fluid in their lungs, so with our primary assessment, if we need to take over breathing for them, we may have to assist them with some positive pressure ventilations. Again, your OPQRST and sample questions are going to be extremely important. Detailed assessment of the cardiovascular system should be done. You should be auscultating lung sounds. You should be looking at capillary refill, identifying pulse and blood pressure, and we may want to get a 12 lead on these patients as well. It's really difficult because this is one of those situations that what we can do is somewhat limited because the patient is in heart failure. We cannot treat the heart failure, but we can help to manage the signs and symptoms. So we want to be sure that advanced life support has been notified. Maybe they are going to tier with us before we arrive to the hospital. We do have CPAP, or that continuous positive airway pressure. We can apply that device, and because of the force of the air, it can help to push some of that fluid back out of the lungs so that the patient breathes a little more easily. We may also administer nitroglycerin, and this is because it will allow for vasodilation, opening things up, hopefully allowing for some of the gas in the lungs or some of that backup in the lungs. The fluid is alleviated. An aneurysm is a weakened section of an arterial wall. Now, when this happens, that area becomes extended or dilated, and it kind of creates a ballooning of that area. The problem with this is if this bursts, the patient can bleed out very quickly, depending on where this aneurysm is located. You may have heard of an aortic aneurysm or a descending aortic aneurysm, abdominal aortic aneurysm. Those are going to be very large aneurysms of very large vessels that can lead to death within a matter of minutes. There are aneurysms that can occur in other arteries as well, but those larger vessels are going to be of greater concern. This just gives you a picture on top. You can see the aneurysm where it's ballooning out, and then a ruptured aneurysm is that lower image where the patient can bleed out wherever the aneurysm is within their body. So if you recall, there are a variety of symptoms for acute coronary syndrome. Sometimes these will be a little more difficult to identify, but please assess your patient, ask the questions, and use what you're receiving as far as your vital signs readings to put all the pieces together and identify these patients quickly if you can. If everything with the primary assessment is okay, we do a secondary assessment. Be sure, again, you are looking and asking lots of questions so that you're getting as much information from the patient as you can. Be sure to include the pertinent negatives. And what I mean by that is if you have a patient who's having chest pain, but they're not having any shortness of breath, we want to include that in our documentation. If you haven't already identified people with chest pain, they get taken care of more quickly. We've got to maintain this high index of suspicion, and we've got to treat patients aggressively. Understand that this is potentially life or death. What interventions are best for your patient? If you are seeing signs of hypoxia, if the patient is short of breath and your pulse ox is low, then providing oxygen is appropriate. We may have to assist the patient, though, with ventilations if they are too weak or are not breathing well on their own. If the patient has their own nitro, we can assist them in taking it. Identify if the patient has already taken some or if they have used their aspirin. We have to be able to identify these patients and get them transported as quickly as possible. Understand that their treatment is really going to be at the hospital to try to manage this issue. And we've got to be sure to keep them alive until then. We also want to make sure that we are taking them to the closest, most appropriate facility. This means I have a cardiac patient. I really would like to take this patient to a hospital with a cath lab, because if I do not take them where there's a cath lab, then the patient is going to need to be transferred again by another ambulance to another hospital, again delaying their care and ultimately causing further damage to the heart. Be sure that you're comfortable with aspirin and nitroglycerin medication administration. Heart failure is a chronic condition. These individuals learn to manage their life and medications to keep them going. Again, recognize the signs and symptoms and treat them aggressively. Don't forget, the heart is our pump, the vessels are the tank, and the blood is the fluid within the body. If the pump is not working efficiently, then the body is not going to be oxygenated well. And this may also cause a decrease in our blood pressure or the pressure within the cardiovascular system. ACS is a term that covers many cardiac issues, but it's especially related to perfusion of the heart. And there are common symptoms that we are likely to see with individuals having an acute coronary syndrome problem. We may also be able to provide our ACS patients with oxygen, nitroglycerin, or aspirin. Follow your protocols, and again, make sure you're transporting the patient to the closest, most appropriate facility. Angina is a condition where we've got narrowing of those vessels. We may have episodes of angina, and some patients may respond really well to rest and nitroglycerin. However, acute myocardial infarctions present very similarly to angina, so we've got to be able to assess these patients quickly, begin our interventions, and get this patient going to the hospital. This poses the question on positioning for patients. If you have a patient who's having difficulty breathing and their blood pressure is 100/70, what is going to be the best position for this patient? This patient is going to probably do better with slightly angling the head of the cot up, and if they do not tolerate that with their blood pressure and their alertness, then we may have to lie them down and assist their breathing. We've got to be sure that the brain is getting circulation and getting that oxygen that it needs. And if our systolic pressure continues to drop lower than 100, then we may be problematic. If they have chest pain and a blood pressure of 180/90, let's sit these people up. Let's get them comfortable. We know that their blood pressure may drop a little bit if they're sitting up, and if their blood pressure is already high, then we can do that. Otherwise, if the patient would rather, we can always put them in a position of comfort at whatever angle that they tolerate best. So tell me what you would do. You now have a 62-year-old female. She's complaining of shortness of breath and chest pain for the last 15 minutes. When you get there, the patient is conscious, but you can tell that she's having some trouble breathing, and her O2 saturation is 88%. What are we going to do for this patient? Well, first of all, let's address our ABCs. Airway, is her airway open? She appears to be breathing, but she's having some trouble. Circulation, what do I have, for skin color? I'm likely going to throw some oxygen on this patient, though, already based off of what I've identified. As we go into the secondary assessment, we need to ask all of the questions to identify what the patient has already done for herself. Does she have underlying respiratory or cardiac problems? And try to work out what the differential diagnoses are for this patient. Get this patient to the hospital, right? We want to be able to transport all of our patients to that higher level of care so that they can be fully evaluated. I hope you all got something out of your cardiac chapter. You can always go back and re-watch or re-attempt the slideshow, but good luck on the quiz.